Okay, folks, I am so freaking happy that our guests are on. Also, I really wish I was closer because these women fill my cup and my heart. And it's like going home every September because I've been back to Mississippi 3 or 4 times now for the state conference, but it's like you see them once a year or maybe twice a year, but God, it feels like these people are in your pocket of your soul all the rest of the year. And it's just amazing. So I have, and I'm not going to get teary eyed, my very sweet friends, Melissa Davis and the one and only Miss Jenna. And these two, y'all, these two women, they, they make Mississippi look easy. And they're
So glad you think that.
well, not like that kind of easy, but like you make it look
Let's define it.
Intraprofessional practice easy because you do such a good job at it. And I
agree. I think we do it well.
Yeah, you do it great. But like I'm walking into today's recording, just so y'all know where I am. I am hot mad on a case that has me so professionally frustrated because I did everything I could to engage in interprofessional practice, and the coordinating SLP on the other end dismissed the attempts, shamed my attempts to the mother, and then violated the child's limited food repertoire. So of the 5 foods, he went down to 2 foods and 2 shakes for several days. And I am hot mad about this, and I'm going to give it to Jesus and he's going to take it away. But my immediate resolution was, how do we fix this so this never happens again? And then, hi, that's where I'm at. I'm mad. Let's make the world a better place. But before we do that, please introduce yourselves and how you got to where you are and what you do. And Jenna, you're in a hotel, so that's fabulous.
I am in a hotel. I am enjoying my lovely background here. So, do you want me to go first, or do you want Melissa to go?
Go for it.
I'm Jenna Nassar. I am a faculty member in the Department of Otolaryngology and Head and Neck Cancer at the University of Mississippi Medical Center. I lead our outpatient pediatric team at Batson Children's Hospital. We see the worst of the worst, the complex of the complex. And it keeps me humble every day. I actually have a background in adult trach and vent, shockingly. That was the first 6 years of my career. But what I loved most about that population is, again, just how fragile and how important, you see the importance of what we do. And that carried over when I moved to pediatrics at Batson about 11 years ago. And I get to work inpatient and outpatient, so I see a little bit of everything. I do get a lot of our NICU grads. We have the state's only level 4 NICU, and so with that comes job security for me because we always have these kids coming back, right? Because, as we know, a lot of the feeding problems specifically are not solved when they leave the NICU. And so I get a lot of those kids, but I have a strong interest in craniofacial development or myofunctional development, things like that. And we see a lot of that come from those kids too. It's a very high genetic population. We see a little bit of everything. So that's kind of where this is where I am at this point in my career. So.
Wait, you're also, is it immediate past president now of the state association, or?
No, I'm still president until December the 31st.
Oh, good Lord, they should be.
So no, I still hold the president thing. Yeah, I'm not done yet.
You just hosted the whole conference. You should be done now, honey.
I did. I am tired. I did that, and then like the following week I went to Disney, and now I'm here with my daughter for show choir competition.
Wow.
So we're just like all over the place. So I'm living on caffeine and adrenaline and
protein shakes.
Jesus.
Yeah. And Jesus. Lots of Jesus.
And Jesus at this point.
Okay.
We're good.
And Melissa and I got to see you receive the fellow from Mississippi. So congratulations.
Honors of the association. Thank you. It was unexpected and brought more tears. And so it's just, but it was nice to receive, especially in the middle of a really large conference where I was highly stressed. So there was a rainbow.
Yeah.
But it was good. And conference was great. And so, and we were so glad to have you back with us. So, but yeah.
Well, thank you. Well, and then I got to bunk with my sweet friend Melissa, who I didn't wake up with my snoring. So huzzah.
No,
there you go.
Not at all. Not at all. You didn't. I did not hear you snoring, which means I probably slept very well. So it wouldn't. It probably would have lulled me back to sleep. So we're all good. It's kind of hard to follow Jenna because she is such an amazing person and she has all these amazing accolades. And I have to agree with Michelle when that conference was amazing. You did a fantastic job. And I think that, your presidency probably should have ended in that, after that conference too, because you worked your tail off.
Tapping out.
But anyway, my name's Melissa Davis. I started out my career after grad school in early intervention in the homes and daycares, and I did that for about 7 years before I went into private practice. I was working very closely with a physical and occupational therapist, and we decided to open the doors of a kids therapy spot for a private practice, and we just thought it was just going to be the three of us. We're like, we just want to see our babies where they'll come to us. And I literally remember going, I think I have about 6 kids that'll come to see me. The rest of them, I'm probably going to have to still go into the homes. And, but that was the beginning. God knew that we needed this very big clinic here in the Golden Triangle. So we now have 2 pretty big outpatient clinics. One's in Starkville, one's in Columbus. These are places 30 minutes away from each other. And then we also provide contracting services in 3 pediatric extended care facilities and a little bit into some the private schools here in Starkville. So needless to say, it's not just the 3 of us anymore. We've got about 40 amazing therapists. They are just all huge blessings, and we get to serve these amazing children. And like Jenna was saying, we receive a lot of medically fragile kids, and we're seeing these rare syndromes and very challenging situations. And my passion developed into pediatric feeding disorders, and it's kind of how I grew to know and love these 2 women on this recording today. So that's me in a nutshell. So like I said, not as many accolades as Jenna, but I'm very honored to have her as a dear friend. And
you run a huge clinic. Do not take that away.
I was ready to say you own
that in itself,
the biggest clinic in Mississippi, and all that. Yeah. Wait, and your baby girl is training to be a speech therapist, and right here, and I sat right here. So folks, if you're not watching live, you're just gonna have to go check out the YouTube. She painted that.
She did that. Mm-hmm.
And so
that was Anna. Yep. Mm-hmm.
I have y'all in my home right there. It's my favorite.
She loves painting that for Michelle, and prayed over it before, she sent it. And she has a talent for sure. And, I kind of always jokingly say she's watched me, go through being in the trenches of what we're doing. And she loves it and still wants to do it for the rest of her life.
Still wants to do it. Yay. Mm-hmm. We haven't scared her off.
Yeah, it didn't discourage her from going in the same direction. So I'm super proud of her and excited. And she's loving school. So, yeah.
Yay. Well, y'all, we chit-chatted about doing an episode together on Intraprofessional Practice. And it originally not from such a hot, mad spot, but from hey, you guys do a really good job with this. Had these high hopes that we were going to record when we got to Mississippi. That didn't happen. But Melissa's daughter got engaged and I got a new job. Those things did happen. So then we pushed this off for 2 weeks. So here we are now. But y'all do a really good job of interprofessional practice. And folks, if you're not sure what that is, interprofessional practice is where you act in your role as a speech pathologist and coordinate care and work together delivering care with an individual outside of your scope. So OT, PT, a physician, a nurse, right? Intraprofessional is where you act within your scope of practice within the world of speech pathology while working in conjunction with another speech pathologist. And it's that continuum of care. And what I find so often is that, especially younger clinicians, they have this I work here, so I'm a better speech therapist. And it's like this little weird ego thing where all of our jobs are hard. All of our jobs come with unique challenges, but God Almighty, they come with joy, they come with laughter. You can find it if you choose it. But each one of our settings requires a unique and different skill set. One is not superior or inferior to another. And I think we need to do more about lifting up how do we do intra professional practice. But that starts with knowing what your scope is within your little area. So, Jenna, if we could start with you, because you're going to get the babies in your NICU, and then they're going to swing out to Melissa. And it'd be cool to hear Melissa's scope and then swing back to Jenna for like a PPAC admission, or not a PPAC, PICU admission, and then swing back to Melissa for the PPAC part. Because that to me is how, like, is that a good rhythm there? Yeah. And then if we could talk about like the scopes within that, like what you do within that framework, and then along the way, okay, but here's my handoff. Here's how I connect. Here's how I did it. That would be lovely because I don't know about y'all, but I learn best through a story and like the case studies. That's how my little brain works. So yeah.
Yeah, we do. Yes, we do.
That we can do.
Yeah. We won't be specific though.
No. But we have some great stories. Should really be simple. So my responsibilities, or I guess my part of this, especially as we kick off with a patient. So we have a designated NICU team. I don't work on specifically on that team, but I follow the babies, especially who, again, we haven't quite gotten everything figured out, right? And we already know that they're going to be back, right? We've gotten them to a point where they're stable enough to go home. Maybe that's with a feeding tube. Maybe it's not, whatever that looks like. And to already have them on radar that we're going to have to get them back in for a swallow study or a clinical. I do the majority of swallow studies at BATS and outpatient, and a lot of them inpatient also. But so that for me, that diagnostic piece, it's not lost on me that I'm lucky that I get to do that, right? But it's really important that what I do translates back to her, right? So if we have a baby who gets home and we already have kind of a follow-up scheduled, maybe we didn't pass a swallow study or not feeding well enough that we're already worried about weight gain and things like that, they're going to come back to me probably within about 8 to 12 weeks, depending on the doctor's preference. And then I feel like there's a few things that really kind of fall into my roles, and it's more so diagnostics that we're still working on getting all the diagnostic pieces put together, right?
And when you say
at the same time, advocacy.
wait, when you say diagnostics, you're not just talking you're working as part of like a team. Who's
Right. Like we may not have everything figured out when they leave the NICU, or even if it's not a NICU situation, even if it's just a complex child, right, that's had prolonged hospital stays and things like that. I feel like for us, first of all, we're still putting the diagnostic puzzle together, whether we've gotten all of the diagnoses figured out and how that pertains to feeding and development and cognitive speech, language, all the things, right? And then alongside that, I feel like a strong role that I still have too is advocacy and really pushing for those things to happen, right? But then on the flip side, even if they get out into the community, it's advocating for them to come back and making sure we're staying on top of getting these things figured out and put together as much as we can anyway, because that makes all of our lives easier. And then communication, because again, as I said a minute ago, it's not lost on me that I have the ability to do these tests that I know oftentimes everybody wishes they could just pull out of their back pocket in a second, right?
If I could get an
And
instrumental like that as opposed to like
right,
waiting.
absolutely right. And so the best that I can do, in terms of getting them where they need to be and helping her, getting them where they need to be, is for me to be as thorough and as detailed as I can be. And that starts with communication prior, communication after, looking at follow-ups and when we need to come back. I'm going to branch really quickly because I do get, and this has become a very passionate topic for me, and she's heard me talk about this a good bit. There's another children's hospital that's not super far from us. We get a lot of second opinions, and a lot of that is coming from the therapist in that direction because they're not getting collaboration and feedback from those therapists. Kid comes in for a swallow study, they get stuck on nectar or honey thickened liquid, and then we'll see you in 6 months for a follow-up swallow study. There's no feedback, there's no communication with the treating therapist. And she's experienced this because she's in North Mississippi, so it's very split sometimes on where those kids end up for further diagnostics. And so
the community-based therapist, when we get this is your altered diet without an anatomical,
right.
physiological etiology, it gives no trajectory for treatment.
Right. And so what are we doing? We're not helping that child. I mean, I've seen kids literally stuck in a hamster wheel for years, some 3+ years. I have to be a part of the plan. I'm very upfront with the parents. Like, I am not the treating therapist. And what I say is not an end all be all. This has got to be collaboration between us. Because I'm not the one in the trenches with that child every week. However, if I don't do my due diligence and I don't give her as much as I can, I'm not helping the child and I'm not helping her. And then everybody kind of starts to suffer and when we stay on the hamster wheel. And so I can tell you, I've done a lot of these kind of second opinion situations where these kids were stuck on thick and liquid, and I've only ever agreed with one, probably out of about 75. And even then, I had a plan, right? Because we're never going to get to thin liquid if we don't ever swallow thin liquid.
Yes.
We're not going to get there. I'll live and die on that hill all day long. If we just constantly stick so then how do we do that, right? And that's where we have to collaborate. It's extremely important that we do that.
So how did y'all meet?
Again, the patient suffers.
How did y'all meet? Like,
we became really good friends the first time you came to Misha.
Yeah.
Yeah.
It was.
That was it.
Are you serious?
We knew of each other, but at that point, like, we had just not connected like that.
I knew on paper. And,
So,
yeah. So,
but I mean, I already knew of the frustrations that existed, because I'd heard it before. I'd heard it from a lot of these parents that are coming. They're frustrated too. We are better than this as a profession, to just stick something on a kid.
Yeah.
And that's it. And because again, the parents aren't even really getting explanations. And sometimes I can't explain everything. I'm not, sometimes I'm just as baffled looking at the swallow study as the next person. Right. But we still have to start somewhere. Mm-hmm. I have to figure it out.
Yeah. So I'll segue into mine. So there's as you're talking, I'm like, I need to say this, and I need to say this, and I need to say this.
You know me better than that, buddy.
No. Yeah, I mean, like bouncing off of you, and I don't want I'm trying to bite my tongue, but kind of when it comes to me, I'm in the trenches out here, and you were talking about new grads, Michelle. When I was a new grad, I went straight into EI in the homes by myself. My CF supervisor was not present. I won't speak to that. But, I start getting all these kids for feeding, which, in grad school didn't have a lot of PFD knowledge at that time. Obviously, now I've got tons of education because that's where I gravitated towards. But, being in the trenches, yes, I'm seeing these children every single day. Every single week. And I get reports. If I do get a report, it feels daunting. Like, especially out of grad school, it's like, I don't feel confident yet to call and speak to this other professional that is so knowledgeable. And this reports, especially from her hospital, is so fantastic. And so I went, ooh, okay. So, I mean, I have to gain a lot of confidence there. And then that comes through competency, as we know. But communication, I swear, once Jenna and I started communicating, now when I know a kid's going to go see her, I'm calling her, I'm talking to the parent going, hey, is it okay if I go ahead and start to talk to the therapist that's going to be doing the swallow study? If she's not doing it, I know someone in her department is, so she's going to get the information to her. I'll get permission from the family, so go ahead and send some videos to her going, this is what we look like. This is what's, going on. And also, I know when to refer to her and when not to. If a kid is super duper orally aversive, I'm not sending them for a swallow study yet. I'm not wasting that time. I'm not going to put the child through that.
It's a common problem right now. Half the kids I've got waiting are just orally aversive.
Yep. So as what we're talking about, what does it look like on a daily basis for me? Of course, I get the referral from the physician. Sometimes that comes with reports. Sometimes it does not. Being the owner of a clinic, I'm able to have a system now where my clinic is registered, where I can actually look online it's through the actual same charts that this hospital has. And so I'm able to get a little bit of knowledge from there. And of course I go down a rabbit hole. Like I literally did an eval 2 days ago, and 2 hours later I go, oh my goodness, I'm reading all these things, trying to figure out what this child, what's going on with this child. Because as we know, I'm trying to get this information from the parents, and they've had so much told to them, they can't know all these things. And so, like Jenna was saying, she tries her very hardest to convey through her reports, this is exactly what's going on. We're also like, I'm talking to mom going, okay, write this down. This is what I want you to ask. If it's not Jenna doing or her hospital doing the swallow study, I'm like, please ask this. And then, like Jenna's saying, I don't get a thorough report all the time. And I don't have a person at each, because I'm 2 hours away from any children's hospital. So in each direction. So I have kids coming to me from possibly 3 different, children's hospitals. Hers, I communicate the best with, and we get the most reports from. And again, when it comes to the intraprofessional practice, I'm so blessed to be able to call her. I tell all my employees too, hey, call Jenna, or tell me and I'll call Jenna and we'll talk about this child. So that is such a blessing. Like Michelle's saying, how do we get contacted? Through MISHA, through our state organization, association convention. But that's not always going to happen. And so it really is, if I have any, kind of suggestion to SLPs that are in the trenches, communicate. Don't be afraid to make a phone call. Really looking at the person's name on there, whether it be, hey, we have a swallow study coming up. I need to do better at this with my other hospitals. If I know one of my kids has a swallow study coming up, hey, mom, will you open your My Chart so I can see the name of the therapist? Try to make that call. Do your best. And then it's up to the other person to get back to you. And so maybe at the very least, if their study, if what they write up is not as thorough as you need it, hey, give me a call after you finish it. So then you can tell us at each phase what was happening. So,
and if they can't tell you, we've got a bigger problem.
Right. Because we do. Jenna's being honest. I'll get something back. The mom will come back and go, we're on honey thickened liquids. And I go, what happened? Like, what's our plan? How long? And it leaves us in the trenches. They're looking at me and I'm asking questions, which may look like I'm questioning a situation, but I go, where do I stand? What do I do now? Like, what do I do in therapy now if that was our only recommendation? So it's hard. It's hard doing these things, but the communication has to start and we have to guide that. I'm blessed to have Jenna in that conversation. Our communication is so open. She knows a kid's coming to her pretty soon, and literally at Michelle, I was like, hey, here's this video of this one kiddo. This is what we're going to be looking at. These are my concerns. I literally saw them on Wednesday, and I'm like, hey, it's coming. We're about to happen. Now, this is one I'm kind of nervous about too, because we are aversive, but We have to get this
But in
done.
situations like that, then we start talking ahead of
Mhm.
time. She'll show them my picture. I've even offered to FaceTime
Mhm.
in with these kids.
Yeah.
If they need to see me, if I just need to be there in a session,
Yeah.
like I'll do that if it's going to get us a more efficient and a clearer picture of a swallow study,
Yeah.
right? If a kid is screaming in my chair and I'm essentially forcing barium, I'm number one causing trauma, which I really don't want to do. I really don't want to do. And it's also not an efficient picture. It's not a clear picture of what they can actually do. Right.
Yeah, exactly.
Claire just got home from
So,
school. Claire says, I love y'all.
it's we.
Oh, I love him too.
So sorry.
Mhm.
So no, but that's a really important piece too, because we're seeing this more and more where I think, the doctors are getting kind of a place where they're like, Hail Mary, you've got a kid that's not eating well. And most of the time, yes, it is probably sensory based issues. We know that, but mom's desperate, doctor's desperate. Let's order a swallow. Great.
So
Fantastic.
Uh-huh.
Yeah,
you.
yeah. Okay. So big picture, I went from the community that I had forged where I knew the people to new setting, new state, new community. And God Almighty, I didn't realize 12 years making community to recreate that somewhere else, it's going to take time. And I am not a patient woman. But what I have found is that there's also, I'm going to choose my words very carefully here. Academic inbreeding can occur when you have internal biasy that you train and hire within and on repeat, and you don't pull in um, robust colleagues' experiences from other settings.
So I've said this about the hospital I was referring to earlier, and this is not a bashing session. It's exactly what you just said. Because when you see swallow study after swallow, like report after report after report, and looks very the same, again, no plan, no collaboration, no, I'm like, there's got to be one person. There's got to be one person that this all fed from.
Yeah.
Like there's got to be somebody at the hierarchy that it's filtering down through, because this is we've got to do better. We have to do better, and we have more research now than we've ever had
We have the
on
baby
thick and liquid and things
NBSIMP.
like. Yes, we've got more than we've ever had, and obviously, I think all of us know that what we were taught, even by way of dysphagia, and not discrediting Logan at all. I mean, she fantastic, led the way, pioneer. But we know more now than we ever did, and half of what we learned has been debunked.
Yes.
Like,
Yes.
Yeah.
The amount of things I have
It
purchased and
absolutely
plucked in the
has.
course of my career.
Mm-hmm.
Yes.
Yes.
Okay.
And so even going back to the concept of, oh, well, they coughed on thin and we moved to thicken, and they didn't cough on that, so we'll stop there. Again, that's not what the research shows now. It's really not. And so again, I feel like a lot of times I'm competing, and it's not, I don't want to sound like that with this other hospital, but it's a more old school mentality. And you always have to stay humble to the learning process. I preached this to our students that were at conference with us 2 weeks ago, because our field is ever evolving. And if you're practicing like you learned, or like just the one person taught you, we're going to get stuck,
Well,
and then the patients suffer.
yes, and that's
Um,
that's
and then this lack of willingness to work with other people, I just feel like we're seeing that more and more and more. And why not? Because it all makes us successful in the end, and the patient themselves, they thrive when we collaborate. So I don't understand why anybody would be against doing that.
so big picture. One, and I know y'all, but folks, if you're going to start this process and you're going to be the source of change, because that's ultimately what we have to do, is we have to woman the ups, man the ups, pick your pronoun the ups. You need a release of information on file. So we get our ROI on record. And then I don't have the luxury, because of the revolving door of who's doing the instrumentals, to know who is doing it in anticipation of, right? Because it's very, very populated. But one of the strategies that I do is I have the parents record me on their phones to play right before. And I try to keep it 1 to 2 minutes or less. Hey, this is my name. This is my alphabet soup. This is what I'm seeing. This is that, like, consolidate. This is specifically what we are concerned for. Heads up, we also have follow-up appointments here, 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 and here. Or we've had diagnostics and we're waiting on the results. That way they capture like a snapshot, right?
Mm-hmm. And that's important. We see them for 30 minutes at that,
yes,
if that. You know, I know nothing about the child coming in.
Yes.
Most of the physician's notes are not going to be super thorough in the end, not explaining what your concerns are.
Yes.
So it's really important.
And I do this not just for my swallow studies, but I do this for when we have an ENT appointment, when we have a GI appointment, like a developmental pediatrician appointment. This is how I can at least, I'm a face, I'm a human. Mom has my phone number. Call me. We have an ROI on file. And I say that in my videos. But what kills me is when I've done this and they don't take the time to watch it, or they dismiss it after I introduce this much. It's like, honey, we have waited this long to get here. Let's go slow. Like, give them time. So theoretically, they go from the hospital. We're getting diagnostics done. We're going into early intervention private practice.
We're getting set up for therapy, right?
So now we're in the therapy world with Melissa, and we're going back for our swallow study. We've had our swallow study. What do y'all do next?
We call. Okay, so Jenna usually will call me, and I'll get the report. So at least, because I'll know when the swallow studies are coming up. So, you know, we're texting. I'm like, hey, let me know how it goes today. And so, you know, days are crazy. So usually like by the end of the day or the next day, she's going to call, then we're going to play phone tag a couple times, and we'll get up with each other. So it's just reality.
It'll happen.
We're great. We, never like texting, but we get up with each other, and she lets me know how it goes, and so then I know. And so, like, I've told her beforehand,
and that's super important because sometimes parents don't translate things.
Oh, it's the opposite. We've had one that's very challenging. It's the opposite. So I need to know exactly from her mouth exactly what happened. It's been, we've had some challenging situations, let's just say. But we continue to communicate is our next step. So, then I know exactly what happened during the study. I told her what this child's going to look like. And sometimes she already knows because they had previously been discharged from the NICU or PICU. And so then we continue to communicate. And so
and I'll give her my opinions about where I think maybe some things to start with in therapy.
Yeah.
But ultimately, she's the one in the trenches there. And then she has to keep me abreast of, kind of what's going on and when she needs me again.
Yeah. And then also I'm able to sit down with the parents and go, okay, I've spoken to Jenna.
Right.
This is what she says. This is what this means. Because as we know, when we're out here, we have to explain. These parents don't know. They're going to so many appointments.
No, they don't. And I can be as thorough as possible. I do playbacks in the suite. I go through everything. I show them, especially if it's aspiration, of course, that's primarily what we're looking for, right? I identify it for them. I show it. But in that moment, life is overwhelming.
Yeah. Mm-hmm.
It's overwhelming.
It's a lot. So,
and they immediately go to doomsday or they go to, yay, I passed, and yes.
Yeah.
Did you study for it?
Yeah.
That's not it. This is not it. But you know what I mean? They can't, there is no gray, it's got to be black or white. I have so many parents that go, but did they pass? I just need to know if they passed, and I'm like, okay, that's not it. Right. We've totally missed the concept. But it's important that I do that. And I know good and well that they're not really taking it all in. So that's another reason that she and I have to talk, because then she has to sit down and
and then two, one great thing that's great. Something that's great is if she and I are talking and I've seen things that have been happening in therapy and that are of concern, then she can actually back me up too and go, hey, this is something that Melissa's been observing. I'm observing it too. This is what it looks like. So if it's something where, not that I'm getting, maybe it's a denial situation kind of thing and they needed to see some proof or whatever. So then we can go, okay, this has been Melissa's concern. This has been the concern going on. I see it too. This is what this is what we should do moving forward.
What it looks like.
Yeah. And so, it's again, it's just a beautiful connection. And again, and she's communicating with my other therapist too. So it's not just us. It's like if they come from my clinic, they're going to be talking. So it's just, I can't talk.
I will do this with anybody.
Yeah. Mm-hmm.
It's important.
Your availability is there. And we're looking at it's not about us, as we know, it's about the child. And so if we keep our communication going, then we're helping the child and we're helping the parent. So, and two, like she was saying, a lot of times if I do have kids that are anxious, I have been known to, hey, Jenna, will you shoot me a picture of you recently? Will you take a picture of the room? Will you film it? And so I had a kiddo who was anxious that was going, and she videoed the room. Like, that child needed to know what to expect. So, with our very medically fragile kids, I then will show a picture and go, this is Jenna, to their parents, to go, okay, this is what to expect. You've been through so much, and this is the person you're going to see. You're going to love her. She's personal. She's personable. She knows you coming in because I've already called her and talked to her. So it's really just making us all be on the same page for that child or that family. So it's just that communication is.
Because I do have a limited amount of time in the radiation suite. I do. At the end of the day, I don't have 2 hours in that room.
Also, those are cold. I wouldn't want to spend 2 hours in those rooms. The radiology suite.
No, nobody wants to spend no, nobody wants to spend even 30 minutes in that room. And especially a child who's already very intimidated by the machine and me and, the white stuff in the cups and all the things, right? I mean, but if I know ahead of time what I'm dealing, because even I always ask the parents, right? Why are you here? Tell me in your words why you're here. But even then, again, they're overwhelmed, right? Or they're in denial. And I don't always get a clear picture. The amount of swallow studies that I've asked the questions, and then like at the end they go, well, we do put oatmeal in the bottle.
Yeah.
And I'm like,
Yeah.
Okay. That would have been nice to know ahead of time. Mm-hmm. Right. It's just, you just don't always get a clear picture even from the parents, and that's not bashing them. Sometimes it's just life for them. So it's really important for me, and it makes the studies go a little easier. They're a little more efficient. I at least know what the concerns are up front, from the person who's most concerned about it. So,
I know some of the really, really big hospitals will have, what is their job title? Child life
specialists. So we have them, and we have one that's assigned to radiology at all times, and she has her bag of tricks and all the things. And so again, if I know, and even if they're in the waiting room, our team will already have her involved before I even see the kid, if it's that bad. So yeah, we're really lucky that we've got our child life specialist, our whole team. And it's not perfect. I look at other hospitals and I see different setups and I think, oh gosh, that would be, but our child life team is phenomenal, and I'm thankful for them.
I've seen how some of them will have, they'll have a video where they record the room beforehand and what it could look like, and they'll play it back. Or I've seen, Melissa, in the private practices where they'll do little scripts of expect this. Have you guys ever? I haven't used tools like that, but I haven't stopped long enough to build something like that, if I'm being honest.
We try to keep everything really fun in the room. So a lot of our MRI and CT suites are themed with fish and a pirate ship and this, that, and the other. My room, unfortunately, did not get a fun theme, but we do have a fun light projection down there that will keep that going. If that kind of calms the kid, we'll turn the lights down lower if that's helpful. We let them have their iPads. I don't care. I need what's normal. And unfortunately, we do know a lot of kids eat with their iPads in front of them. And if that's normal for them, I'm perfectly fine with that. I don't mind in that moment, especially if it's going to get me what I need. without having to traumatize them, because that's the one thing that I dislike about swallow studies, is the amount of kids that I have to traumatize in the process, just for a picture of what I 99.9% of the time already know is going to look like. It is rare. I've done swallow studies my whole career. I've had the setup ability, whatever you want to say. And I'm extremely lucky, and I love to do them. But, it's just not, it's not always needed, and it's the one thing that I dislike about it is that, we, again, kind of, if they're over ordered sometimes, in situations where there's no pulmonary issues, there's no, like it's a true picky eater. We're working them up for various things. Maybe they have some other things on board already. And we just automatically go to this place. And I think a lot of it, again, just comes from parent desperation of my child is only eating 2 or 3 items. And most of these kids are already in speech. And a lot of these younger clinicians, or again, because we know that the curriculum is not great for feeding. We know that. Let's call that out. Or I will.
I'm 100% behind
it. Is what it is. It's not good enough.
Uh-huh.
And we need to do better as a whole. But these young and older graduates at that are not getting what they need, and they start their jobs and they have no idea what they're doing when it comes to feeding. And the amount of kids that I do swallow studies on, that the parents will say, well, they won't start until we get this done.
Mm-hmm.
What?
And that's old school, because I remember probably getting out of grad school going, oh, so I can't start anything swallowing wise until I get a swallow. So that's kind of an old school mentality.
When did we do that?
I know. And now I haven't.
You send them to me, or not you?
No. I'm the one going. No,
send them to me, and we can't get a spoon near their mouth.
Mm-hmm. Yeah.
So could we have started there? You could have done that.
Mm-hmm.
That's appropriate. If you're nervous about feeding this child, I understand your feelings are valid. But again, let's look at the big picture. Because most of these kids, right, that are highly sensory are probably drinking Pediasure from a soft spout sippy cup or a bottle, right? Mm-hmm. We're living off of that.
1,000%.
Okay, so we're managing that, and we're not sick.
Uh-huh.
We gag with any texture, right? Like, let's just talk about our classic cases. Well, let's do a swallow study. I'm scared of them. The gagging scares them because we have this very warped idea that gagging is choking.
Yes.
It's not. Those are different things.
No, I know that.
Oh, yes, but I'm affirming for the people that can't see our.
But again, so that they are not the same thing, because when a parent says that to me, when they come in and go, well, we see them choking.
Yep.
So you see them lose their airway and turn blue. Those are the first 2 things I ask.
Yeah.
Well, no. Okay, so then you're probably seeing them gag. Would you agree with me that that's kind of, you see them more just have a reaction orally?
Mm-hmm.
Yes. Okay. That's very different.
Mm-hmm.
But you've got these younger therapists, older therapists, untrained therapists, right?
Untrained
and that's
is
not
the word.
I mean, this is just one of those situations that they get stuck in. They're in a job where, they're telling them they have to see some of these kids. They're not prepared for these kids. They haven't had the chance to be trained or get more, and their first initial thought is that I'm not touching them until I know they can safely swallow.
Yeah.
When we really have no evidence they cannot safely swallow. Yeah. They're drinking Pediasure. Right. They're eating one puree. They can swallow.
So
we have got to do better.
I hear this a lot as we're expanding to add pediatric feeding and swallowing disorders in the public schools, which is where they should be served, because kids turn 3 and it goes with them, right? Kristen West was the one, that first person I heard say that, like, it doesn't stop when they walk in the front door. But like, my concern is, without clear guidelines, that misinformation will continue there. But Melissa Diwali, back to clinical decision making, what are you looking for in the community, especially in those PPECs? Because a PPEC is kind of like a school to say, okay, this is this is now when we need a swallow study. What are your triage list, for lack of a better phrase, to try to kick it back to Jenna when they're older or when we think it's indicated?
So with the PPEC, those are more medical facilities. So the majority of those are being followed by complex care. They're at hospitals. So luckily, we have I'm communicating with the nurses there on staff every day. I'm communicating with them and going, okay, well, this child's doing this. It's time for them to go back to possibly do another swallow study. But we have to look at the readiness. At the end of the day, we have to look at the readiness. Have we, a lot of those kids coming into a PPEC, since they're so medically fragile, they've had a swallow study most likely before they've come there. A lot of them have feeding tubes. So then I have to go, okay, have we made a little bit of progress where we need to see another picture, or have we had a dip to where we need to see if something's going on?
I love how your face was like, do we need to see progress, or do we need to see?
My hands go with it. I try my hard. I've been holding a pencil, so I don't talk with my hands, but I dropped it. So I'm going to pick it back up
down a while ago.
But I'm so good at talking with my hands.
So we're all thriving.
There we go. So, but at the end of the day, like Jenna was saying, I have to look at my understanding of, is this child ready for this swallow study yet? Whether it be, am I looking at the medical situation? Am I looking at, if we're super duper orally aversive, I am not sending that child for a swallow study. But that's hard because I'm having to talk to the parent about why I'm making that decision. And I have to tell them, hey, would you like for us to cause more trauma on trauma? And we don't want that, which then I have to say, okay, that will obviously affect our progress being made, because then we have a negative association to food suddenly. And then, yes, they hate Jenna. Yes, and then a negative association to Jenna. So then if we get, then if we do get to where we are ready in the future, sending them back to Jenna, she's going to have somebody else in there because they hate her, because they look at her and go, she caused me trauma.
I'm associated with the problem.
Yeah. So it goes back to what she's saying, when you're the therapist they're treating, we have to have the training. I know I can pick and choose because it's my clinic, but if a child, if I'm hiring somebody, if they want to do feeding, any kind of therapy in the feeding world, they're going to have training, and we're going to sit down and we're going to talk a lot about things ongoing. I'm not going to ask you to treat a child for any kind of feeding disorder if you don't have the training and the knowledge beyond grad school.
That's a huge part of interprofessional practice is predicated on the education, that intra and interprofessional education. If you want to be a good partner, you ready yourself. And that's something that there's inherent barriers to that. If we're going to call it, we've got barriers from a academic clinical experience. There's very few faculty to actually teach pediatric feeding and swallowing because most grad programs don't have it as a standalone class. If we triage that further, those that do may not have had clinical experience, and then carry that over another step. How many university clinics actually have that in their clinic, which is even more rare? And then we don't have great textbooks on how to do this. I mean, there's a couple of us out there that have tried, but it's hard, an evolution of science. But we do not have a pediatric medical SLP textbook. I mean, hell's bells, I've looked hard for that one. But then you graduate, and the sheer cost of getting the CEUs, of maintaining your licensure, of there's so many financial barriers.
So, yeah.
Mm-hmm. And but you nailed it on that, because that's my biggest suggestion is, when we graduate, whether we got the knowledge there or we had a placement in PFD, you're blessed with doing that, but continuing to get that education. So we're not going like Jenna. Yeah, exactly. Like Jenna was saying earlier, we don't want to have just this one set way of this is what treating PFD looks like. No, we have to continue. Because again, I look back on myself 20 years ago. Oh my goodness, I'm a totally different therapist. So I mean, I look back,
even
so I
5 years
can't.
ago, I think about
Yeah, I can't believe I did
things
so and so. And I mean, I'll even fess up to parents too and go, I used to do so and so, but I don't do that anymore. So because I've had the education, I've gotten more knowledge, I've done more research.
Well, and
So
again, things just evolved.
yes, yeah.
Things are changing; they're ever changing, and that's why you have to stay humble to the learning
Yes,
process
it
for
humbles
sure.
the word, yes,
Um,
and know that what we think is not the only way. So,
well, and I think too, kind of going back to what we were just talking about in terms of like knowing readiness for like we want to look at overall readiness, and just the status of the patient too. Like she referred to our complex care team. That's another great thing that Batson does well, and I am thankful for that team because number one, they are super communicative. And they're our palliative care team that we renamed probably 10 years ago to complex care. Because obviously, that other word is a little scary. And while they still see those patients and handle all of those things too, this team solely just sees these medically complex kids and making sure that they're getting everything they need, that they're growing, that their tube feeding is being adjusted. The amount of pediatricians that were supposed to take over adjusting tube feeding when they discharged from the hospital that didn't happen. Things fall through the cracks. I refer just about every kid I see to complex care if they're not already set up because NICU follow-up stops at age 2. Once they get to 2, we have aged out of NICU follow-up, right? And so they need it. Oh, 100%. 100%. So that team is my saving grace a lot of days. And they're looking at the same thing we are. What is their overall status? Are we growing? Are we constantly keeping respiratory infections? Are we, seeing progress in all therapies? Because we know good nutrition drives all of that, right? So so we look at all of those things when we determine if we need to see him back and when we need to see him back and all of those things. And again, it just goes back to basic communication. Just being willing to make the phone call, send the message, have the conversation.
and like from my end, don't be afraid to have those conversations with those physicians. I
Right.
mean, open the door with another
Absolutely.
speech pathologist, which is fantastic, because we can look at the kid across the board, but also calling those physicians. So talking to IBP for just a little bit,
Yeah.
just be
Yes.
confident and, prepare your conversation before you speak because it is intimidating when you're calling from afar and they don't know who I am.
It is. It
Making
is.
that
I can
call,
speak.
we have to. So.
Most of our team is willing and they want to hear, and I'm like you don't want to take up a lot of their time and you gotta be short and sweet with your message, and efficient. But overall, they know that we're the ones seeing the kids every day. Whether it's my own outpatient caseload, your outpatient caseload, we catch things that they don't. They know that. They know that. So
one piece for me that I go back to is evolution of when is the swallow study necessary? And again, that's a huge growth curve clinically, right? But what I have found is that I'm very rarely sent for a swallow study now because when I'm looking at the actual diagnosis of the pediatric feeding disorder, so crash course friendly reminder, there's 4 domains: the medical, the feeding skill, nutrition, and psychosocial. It's typically underlying medical that's driving the behavioral choice. I don't want to eat this, but that's predicated on I have a negative sensory experience, but that sensory experience is coming from whatever the medical is going on. And it could be a sensory processing disorder. It could be GI. It could be allergies. It could be a whole host of insert etiology. But I have to do my part to help them figure out that piece. And some of my favorite resources, and I'm writing these down so that we can add them to the show notes. Um, I love Bowel Sounds by Nasafgan. It's the pediatric GI one. It's so user family friendly. I love Nutrition Pearls by the registered dietitian extension of Nasafgan, where they have RDs come on and troubleshoot cases, troubleshoot solutions. But what's cool is I can send the caregivers out the door with, hey, listen to this. Hey, here's a resource. And Feeding Matters has their own podcast now called Feeding Does Matter. And that's amazing, where they're interviewing subject matter experts. And they have, I'm going to do this wrong, Dr. Haley Eastrom. Are y'all familiar with her? She's actually not an SLP, but her own little one had ARFID. And so they're her lived experiences. And it's so cool because the caregivers can hear the content and feel empowered, so that when Melissa's lifting them up and you're lifting them up, then they have an impartial third party that's also lifting them up, so that when they go to the big scary GI appointments or all of these other interprofessional practice appointments, they feel as ready as we can make them. And that knowledge is evidence-based from those sources, and it's free. So that's freaking cool. Yeah. Also, that baby MBS IMP, I got it, but I haven't taken it yet. It's on my to-do list. Have you done
I
it yet?
have it too. I haven't finished it yet.
It's hard.
It'll happen.
Yes.
It'll happen.
Yes. It's a great course, but they were norming that out of Charleston. And I think that's why I got so spoiled, was because I was able to send everybody to MUSC, but they were doing the normative data on it. And so it was like the center for best practice, and then I moved.
Yeah. I think something else we have to think about too, especially when it comes to swallow study referrals, besides just the status of the patient and what they actually look like, right? And do we really feel like, are they truly aspirating, and how's it impacting them? But beyond that, we also have to look at, like, I can't unsee what I see, right? Where are we really going with it, right? So once we determine, or we figured out this child is aspirating, are we even at a place where we want to pursue a feeding tube? And I'm more asking these questions out loud because this is what goes through my brain, right? What's the end goal? Like, just to know they're aspirating, I mean, where are we at medically? And this may sound stupid, I don't know, but that's just where my mind goes, is what are we really after? Because I can tell you, the majority of parents that walk in the radiology suite don't want a tube. They don't want anything to do with the tube. Half of them don't even know that's a possibility. So again, what's the end goal? Is it going to change our treatment plan? And I'm not saying it's not. I'm literally just asking the questions that I think about too with some of these cases that I see. Because again, it's maybe happening and it's not impacting their overall health and function and things like that. I mean, I always go back to this, like, what are we after? Because we do know that we all aspirate and we all have moments of incoordination and right. And so there's a level of normalcy.
Yes. My 12-year-old, every time he tries to chug multiple big sips, he chokes and sputters. And we all were like, Bubby, did you aspirate? He's like, it's just flash penetration.
That's all it is. And we do, and that's what I'm saying. So, like, for some of these situations where and I mean, sometimes it's a random occurrence. Like, sometimes, I really think, I don't know what they're looking for, but, I'll see them aspirate. And then it's like, okay, where are we going from here? Well, I mean, the child's fine. They don't have any history of respiratory issues. They're growing fine. Their intake is fine. So we monitor. We don't make any crazy changes. I'm not just going to stick a kid with a tube. Because but I think, again, it goes back to, like, what are we after in this swallow study? And then that goes back to, again, like, what are you seeing? What are you seeing from the kid in the room? Right. I just think we're just so quick to order that because it's always been this gold standard test. And it is, in my opinion, but not for every situation.
Right. Right. And I think, again, that just goes back to our knowledge as a feeding, specialists in feeding.
Yeah.
Because, I mean, and I'm sitting here thinking as you're talking, I'm like, when I send a kid to Jenna for a swallow study, we get a swallow study. When it's at a different place, they're going to have to go back again. because we're coming back on honey thickened or something like that, which means we're going to have to go back. So if the question is, why are we getting another one?
Why would I
maybe so we can not be on honey thickened liquids. So,
and I certainly don't want to do that if they're not having sensation.
Right.
That's another thing that I keep seeing other people do. Why would I do that?
Yeah.
I would much rather them aspirate water
than
honey.
So it's the whole situation is hard, but again, open communication. It's key, and because then you will know the why. Before the kid gets there, what is the why? What's our expectation from this?
Well, and
if we're doing as well as we think we are, sometimes, and to go, for approval, or sometimes it's, hey, I know this kid's not doing that well. I need your help to, really prepare mom. So, and a lot of times I've already prepared them for feeding tube discussion too. So, but in a positive way.
I have to take it back to when you talk about the communication piece. That's something that, yes, it comes from fear, but I have seen your state association systematically embed peds medical. And that's systematic. And wearing as president hat, I can tell you a lot of state associations typically draw in and focus on school-based clinicians. So peds adults, and especially peds adults, peds medical and adult medical tend to be areas where they're not systematically seeking out those members. But if you want to create opportunities for improved continuity of care across the state, then host your conference, invite practitioners from the different settings, and create that opportunity. That's why, I make it a point. Introduce yourselves in the room. Introduce, where are you? What setting do you do? That's systematic, because then you have a network by time we're done, right?
Yeah.
But
I like to think, and Melissa can kind of attest to this, like with Misha, it's not always been that way. This was something that started slowly shifting. So I've been a part of Misha for 8 years in some capacity of some kind of officer, something or another. And so for us, when I got involved with conference 8 years ago, I noticed that, because I'd just not been a big part of Misha up until that point. And after that, it just slowly started to evolve, especially with new board members and stuff like that, having a really strong VP of healthcare at all times that will advocate to make sure that we constantly have some kind of presence, with medical. Because our goal was to grow conference, right? But also grow in diversity of the therapists that we have there in terms of site practice, right? Like where they're working, what they can bring to the table. And so it's, for us, it just became a mission, a goal, just with, again, I think a changing of the guard. So
you can say it's appropriate.
Yep.
But it just became, because I feel like a state association should represent
everybody,
yes.
Right?
But again, that's systematic.
I know.
And that's
I know. And I hope what I just said is encouraging to somebody that listens.
Yeah, but it's true, though.
It can be done, and it should be done.
Yeah.
Get these people. I'll come speak. They'll come speak. Get people to come that's willing to talk about the trenches and what we do, because this topic is not going away. If anything, it's only getting more and more prevalent.
Yeah.
Pediatric feeding disorders we know more now than we ever have, and it's only going up.
Yes.
So.
But you're very correct, because I was sitting there thinking about when have I gotten really active with Misha? The last 5 years. Yeah. I wasn't before that, because I was like, I don't need to go to learn anything about the school setting. I'm not in the school setting. I've never been in the school setting. There's some wonderful therapists there. I'm not there. So I need to, if I'm going to go to a conference, it's going to be about something I can apply to my practice. So
absolutely.
So it's yeah.
And we've tried to shift everything, offering more for private practice, always having Medicaid there with all of our funding and things like that. we've tried to just make it more diverse across the board. So it does bring in a variety of therapists, because again, we should be supporting every
Yeah.
genre.
And we need to know the reality when we graduate too. If you're going into private practice, these girls need to know what it looks like. Behind the scenes billing stuff is a nightmare, but to have Medicaid there, I came back. Some things have happened since I've been back. They got done because I met people. And
hopefully it's only going to get better.
Yeah. So fingers crossed. But girls need to know the reality of what's expected from a private practice too. When they're practicing, we've got to get authorizations for insurance. So again, the communication has to be there. The education has to be there. So, yeah.
Okay. I love y'all, and we could keep going.
Yeah.
But Mr. Dawson's going to fly in like the wind with Goose Danger Dawson, and everybody's going to have to throw on bathing suits because Goose has started putting his face in the water. We've been doing swim lessons for a gabillion years, and now he'll pinch his nose and he'll put his whole face under the water. And I'm so excited, but it's like everybody cheering on. And I also know that being late stresses my neurodivergent family out.
It's okay.
I wonder where they get this.
We understand.
Yes.
Yeah.
Anytime.
But really quickly, if you could give folks one sentence of hope.
Oh, goodness.
Or tell us if somebody is so inspired and they want to do a little love money donation, is there an organization or an entity that you would recommend that they could donate to or support? It could be a scholarship. It could be missions trip. It could be any of the above, something that's just meaningful to you as a human. Yeah.
Feeding Matters is near and dear to my heart.
Yeah. I was going to say this.
I have to say that.
That organization alone just pours so much back into families.
Mm-hmm.
This is 3 for 4 in the last 24 hours, and that makes my heart so happy. And the lovely lady, Dr. Talbot from Australia, said Butterfly Foundation, and I thought it was a butterfly foundation. No, it's actually the name of their eating disorders crew in Australia. Wow. But I thought it was I was like, we've never supported butterflies before.
But we're going to now.
That's awesome.
So
I love it.
I was equally happy it's a good cause, but also somebody needs to come out and say a butterfly organization.
That's good stuff. But I guess, like Jenna said, it's kind of hard to say words of encouragement, but if I can say anything, it's to really, how we're supposed to empower parents. We need to empower ourselves too and believe in what we're doing. And if we don't understand something, let's go get educated and let's talk to each other. And let's not think that we're supposed to come and know all the things. Let's lean on each other because it's not about us. It's about the kids, and just believe in ourselves and lean on each other is the biggest thing that I can say.
I said this to a group of students 2 weeks ago, and I think it applies to us all. It's just to be extremely humble to the learning process because our field evolves every day, and always strive just to be better. Mm-hmm. That at the end of the day, if we're not doing that, then I think it's time to go home.
Yeah. If you're
move into a different profession.
Yeah.
Because I think it's just important that you continue to push yourself just to be better. And it's not by way of perfectionism by any means. That's not what I'm talking about. It's just, it's just to be better.
Mm-hmm. And continue to learn.
Yeah.
Thank you for having me.
Thank y'all so much for coming on. For the laughs. All right, ladies. Thank you.
Love y'all. Y'all have a good night. Thank you for having us, Michelle.
Bye.